In a clinical case, an 18-year-old male comes to the clinic for a routine checkup. He is healthy and has no outstanding past medical history. On chest auscultation, the doctor hears a mid-systolic click and he denies having any symptoms. Background and incident. Mitral valve prolapse can be defined as the bulging of one or both mitral valve leaflets into the left atrium during systole. It can be familial or occur sporadically and affect approximately 2 to 3 of the U.S. population. It is also the most common valvular abnormality. Mitral valve prolapse is a common cause of isolated mitral regurgitation, which is the backflow of blood from the left ventricle into the left atrium during ventricular contraction, and this usually requires surgical repair. It is usually benign and asymptomatic, just like the clinical case that we mentioned earlier on. It's sometimes accidentally diagnosed, and occasionally it can lead to serious complications such as infective endocarditis, sudden cardiac death, and cerebral vascular ischemic event. Epidemiology. Mitral valve prolapse commonly occur alongside connective tissues disorders such as Marfan syndrome, Ehlers-Danlos syndrome, and osteogenesis imperfecta. It has also been in individuals of all ages and thought to be inherited, with increased incidence in female than in male, with a ratio of 2:1. It is mostly an autosomal dominant disease. It has also been seen in X-linked cases.
The human heart consists of 4 chambers: the right atrium, right ventricle, left atrium, and left ventricle. The atriums of the heart acts as the receiving chambers. The right atrium receives blood from the superior and inferior vena cava, and the left atrium receives blood from the pulmonary veins. Once blood is filled in these chambers, they simultaneously contract, pushing blood into the ventricle chambers of the heart. The ventricles are known as the primary pumping chambers of the heart, driving blood into the lungs and rest of the body. The right ventricle is responsible for pushing deoxygenated blood into the pulmonary circuit or pulmonary trunk, which guides to the lungs and then divides into the left and right pulmonary arteries. The pulmonary vessels are branched many times before eventually leading to the pulmonary capillaries located in the lungs, where gas exchange occurs. The deoxygenated blood has now undergone gas exchange, ridding the carbon dioxide and gaining oxygen in the blood. While the right ventricle is responsible for pushing deoxygenated blood into the pulmonary circuit, the left ventricle is responsible for pushing oxygenated blood into the systemic circuit, or the rest of the body. After deoxygenated blood has undergone gas exchange in the pulmonary circuit, the oxygenated blood then leads into the left atrium by the help of the pulmonary veins. The left atrium contracts, conducting the blood into the left ventricle. Once the left ventricle contracts, the oxygenated blood leads into the aorta and continues to many other branches of the systemic circuit within the body. The branches of the systemic circuit will eventually lead to the systemic capillaries, where oxygen and nutrients are exchanged for the tissue cells of the body to use. The blood that is exiting these capillaries are much lower in oxygen than they were traveling in. The systemic capillaries eventually branch to form venules, which unites to form larger veins. The low oxygenated blood that is flowing in the larger veins eventually leads to the superior and inferior vena cava, draining the blood back into the right atrium. The cardiac conduction system allows for a fully developed adult heart to generate its own electrical pulse. The components of the cardiac conduction system include the sinoatrial node, or SA node, the atrioventricular node, or AV node, the atrioventricular bundle, the atrioventricular bundle branches, and the Purkinje cells. The SA node is a specialized clump of myocardial conducting cells located in the superior and posterior walls of the right atrium, and it initiates the normal electrical pattern followed by contraction of the heart. It has the highest inherent rate of depolarization and is known as the pacemaker of the heart. It initiates the normal electrical pattern followed by contraction of the heart. The AV node is a second clump of specialized myocardial conductive cells that is located in the inferior portion of the right atrium within the atrioventricular septum. The septum stops the impulse from spreading directly to the ventricles without passing through the AV node. The atrioventricular bundle arises from the AV node and proceeds through the interventricular septum before splitting into two atrioventricular bundle branches. The left bundle branch supplies the left ventricle, and the right bundle branch supplies the right ventricle. The Purkinje cells, or Purkinje fibers, are additional myocardial conductive fibers that spread the impulse to the myocardial contractile cells in the ventricles. They extend throughout the myocardium from the apex of the heart toward the atrioventricular septum and the base of the heart. The cardiac conduction system starts with the SA node and the remainder of the conduction system at rest due to the resting membrane potential. The SA node then initiates the action potential, which creates spontaneous depolarization due to the influx of fast sodium ions until the threshold is reached, thus sweeping across the atria. After electrical signal reaches the AV node, there is a critical pause or plateau phase of the action potential before the atria depolarizes and contracts. This allows for the atria to complete pumping before the signal is transmitted to the atrioventricular bundle. The plateau phase of the action potential is due to the opening of voltage-gated slow calcium ions and closing of some of the potassium channels. Following the delay of the impulse to the atrioventricular bundles, the impulse signal travels through those atrioventricular bundles and bundle branches to the Purkinje fibers. The action potential reflects this region of the conduction system by repolarization due to opening of voltage-gated potassium channels and closing of potassium channels. The impulse then spreads to the contractile fibers of the ventricles and ventricular contraction begins. As the action potential travels through this portion of the conduction system, the ventricles depolarize and contract. The human heart consists of 4 valves to ensure unidirectional blood flows through the heart. The right atrium and right ventricle have the tricuspid valve between them. The tricuspid valve is composed of 3 flaps that are made of endocardium that is reinforced with connective tissue. The tricuspid valve is connected by the chordae tendineae to the papillary muscles, which control the opening and closing of the heart. At the base of the pulmonary trunk is the pulmonary valve. The pulmonary valve also consists of 3 flaps. They are made of endothelium reinforced with connective tissue and are not connected by chordae tendineae. When the right ventricle is relaxed, the pressure differential causes blood to flow back into the ventricle from the pulmonary trunk. This flow of blood fills the flaps of the pulmonary valve, causing the valve to close and producing an audible sound. The left atrium and left ventricle have the mitral valve between them. The mitral valve consists of 2 cusps that are attached by the chordae tendineae to 2 papillary muscles that project from the wall of the ventricle. The aortic valve is found at the base of the aorta and normally consists of 3 flaps. This aorta valve prevents the backflow of blood from the aorta. When the left ventricle relaxes and blood tries to flow back into the ventricle from the aorta, blood will fill the cusps of the valve, causing it to close and producing an audible sound. When both the atria and ventricles are relaxed, and when the atria contract to push blood into the ventricles, this causes the tricuspid and mitral valve to open and the pulmonary and aortic valve to close. The opposite occurs when the ventricles contract to push blood into the aorta and pulmonary trunk. The tricuspid and mitral valve are closed, and the aorta and pulmonary valve are open. When the ventricles contract, areas of high blood pressure flow to areas of low blood pressure, which would be the atria. This backflow of blood causes the tricuspid and mitral valves to close. When the heart is relaxed, so are papillary muscles, which causes the tension to decrease on the chordae tendineae. However, when the ventricles contract, so do the papillary muscles, causing tension on the chordae tendineae. The chordae tendineae helps hold the cusps of the mitral and tricuspid valves in place and preventing them from being blown back into the atria. Mitral valve prolapse occurs when there is improper closure of the mitral valve when the heart contracts. This could be due to one or both of the flaps not closing properly, allowing blood to leak back into the left atrium. Although mitral valve prolapse is not life-threatening, it could cause other complications such as mitral valve regurgitation. Mitral valve regurgitation could overall affect the cardiac output. When the left ventricle contracts, the prolapsed mitral valve ejects some of its stroke volume into the left atrium, thus decreasing the forwarding cardio output. Cardio output is the measurement of blood that is being pumped by each ventricle a minute at a time. To calculate the cardio output, one must include the stroke volume and heart rate. The stroke volume is the amount of blood being pumped by the ventricles. Stroke volume is important because it could have impact on a cardiac function if it is altered anyway. Stroke volume depends on the preload, which is the stretch on the ventricles prior to contraction, the contractility, which is the force or strength of the contraction itself, and the afterload, which is the force the ventricles must generate to pump blood against the resistance in the vessels. Filling time of the heart ventricles is an important component of stroke volume preload. The more rapid the heart contracts, the shorter the filling time, thus decreasing preload. When ventricular filling time is increased, so is the preload. With preload at a greater degree, the cardiac muscle itself is also stretched to a greater degree. When increased ventricular filling is present, the ventricular muscle is increasingly stretched and the sacromeres length increases. As the sacromeres reach their optimal lengths, they will contract more powerfully. When the ventricles are at rest, the cardiac muscle has little stretch. While preload is an important component of stroke volume, contractility is just as important because it controls the stroke volume. The more forceful the contraction, the greater the stroke volume. Afterload, on the other hand, refers to the tension that the ventricles must develop to pump blood effectively against the resistance in the vascular system. Any condition that increases this resistance, a greater afterload will be required to force open the semilunar valves and pump the blood.
Signs refer to objective, measured factors that physicians are able to identify or measure in a clinical setting. There are a couple different signs that healthcare providers are able to identify when dealing with mitral valve prolapse. First and foremost would be abnormal heart rhythms. When using a stethoscope to listen for a patient's heart rhythm, in the instance that an individual has mitral valve prolapse, the doctor will hear an abnormal heart rhythm. Normally, the heart makes a lub sound that represents the closing of the mitral and tricuspid valves, and then a dub sound, which represents the closing of the pulmonary and aortic valves. In MVP, the doctor would hear a slight whoosh sound in between the normal lub-dub heart sounds. This would represent some blood moving back into the left atrium and not completely being pushed into the left ventricle. The picture on the right exhibits this idea very well, as we see the difference between a normal heart and a heart with MVP. In a normal heart, the mitral valve fully closes, emptying all the blood from the left atrium into the left ventricle. However, in the MVP heart, we are able to see some regurgitation as a bit of blood flows backward into the left atrium instead of fully emptying into the left ventricle. Another sign of mitral valve prolapse is orthostatic hypotension, which refers to an abnormally low blood pressure when an individual stands up. When a normal individual stands up from a sitting position, blood rushes to the legs and blood pressure temporarily dips. Normally, in order to combat this, heart rate and blood pressure increase in order to get blood back to the heart and eventually circulate throughout the body. When an individual with MVP experiences orthostatic hypotension, they tend to also experience symptoms like lightheadedness and dizziness, because their body is taking longer than normal to increase their heart rate and blood pressure. This delay is partly due to the regurgitation of oxygen-rich blood back into the left atrium, making it more difficult to quickly increase blood pressure and heart rate to relieve the temporary dip in blood pressure from standing up. The mechanism associated with orthostatic hypotension is also closely linked to another sign of mitral valve prolapse, syncope. Syncope refers to fainting episodes. In certain occasions, for individuals with MVP, the time it takes for the body to successfully increase blood pressure and heart rate from orthostatic hypotension can be quite significant. This delay takes a toll on the body, and instead of simply experiencing short-term dizziness, some individuals can experience fainting episodes, where they lose consciousness for some time. The picture on the right explains this idea. Here we can see the difference between a normal individual's body responding to a drop in blood pressure that occurs when going from a sitting position to a standing position, Their body reacts by increasing heart rate and blood pressure in order to return blood to the heart, where it can then be circulated to the rest of the body. On the other hand, the other individual's body has not adequately increased blood pressure or heart rate, causing cerebral symptoms like dizziness, which could eventually lead to fainting. Now we move to symptoms associated with MVP. Symptoms are subjective experiences that refer to feelings or sensations that patients have. They cannot always be definitively measured or observed by providers. There are many symptoms associated with mitral valve prolapse. However, it is worthy to note that some individuals who have mitral valve prolapse are asymptomatic, meaning they experience no physical symptoms of this condition. In these cases, the only way this individual would be diagnosed would be through yearly checkups with their doctors when checking for normal heart rhythms. To begin, fatigue is commonly a symptom associated with mitral valve prolapse. In a normal heart, circulating oxygen-rich blood to the rest of the body is not a problem because blood fully empties from the left atrium to the left ventricle. However, in MVP, if there is oxygen-rich blood leaking back into the left atrium, this means there is less oxygen-rich blood circulating to the rest of the body, which can cause feelings of fatigue and tiredness. This fatigue can even worsen to difficulty breathing or shortness of breath. These symptoms are again due to the fact that there is not as much oxygen-rich blood reaching body tissues, which allows the body to quickly tire out, resulting in shortness of breath. The picture on the left just shows an individual experiencing fatigue and shortness of breath, both common symptoms of mitral valve prolapse. As previously discussed, a common symptom that is linked to the mechanism of orthostatic hypotension, which is a sign of MVP, is lightheadedness and dizziness. An individual with MVP tends to take longer than normal to increase their heart rate and blood pressure in response to the temporary dip in blood pressure when going from a sitting to a standing position. This delay means that the body can experience dizziness or lightheadedness. Further, as previously mentioned, those with MVP have less oxygen-rich blood circulating to the rest of their body because some oxygen-rich blood is regurgitated back into the left atrium. This means less oxygen-rich blood circulating to very important areas, including the brain, which can cause temporary physical feelings of dizziness or lightheadedness. Lastly, many individuals with MVP experience palpitations, feelings that are similar to a pounding or racing of the heart. These feelings are directly related to the regurgitation of oxygen-rich blood flowing back into the left atrium instead of completely emptying into the left ventricle. In some serious cases, the constant regurgitation of blood into the left atrium can cause chest discomfort and chest pain. This pain ranges from simple discomfort to severely incapacitating, based on the case, and can also range from acute to long-term. The picture on the right shows some of the common causes of chest pain, one of which is MVP. The picture is important because while chest pain is one of the most frequently seen symptoms of MVP, there's no way to determine an MVP diagnosis just based off of this symptom, especially since so many diseases can cause chest pain. Only when a doctor compounds an individual's signs and symptoms, listens to their heart rhythm, performs an ECG or EKG to visualize a heart cycle, can they definitively diagnose an individual with MVP.
There are many different methods to diagnose MVP. Usually a physical exam takes place prior to diagnosing mitral valve prolapse. One of the first methods is using a stethoscope. If a patient has MVP, clicking sounds are likely to be detected. If there is blood that is leaking backwards into the mitral valve, heart murmurs or whooshing sounds will be heard through the stethoscope. On the left, we have an echocardiogram, which is like an ultrasound for one's heart. A transducer is put on patient's chest in the area where heart is detected, and transducer records sound waves from your heart, creating an image of it. With an echocardiogram, sound waves are used to create images of the heart when in motion. Echocardiograms can help confirm and diagnose MVP, as well as help to determine how severe it may be for the patient. TTE, which stands for transthoracic echocardiogram, is when the transducer is attached to the end of a tube and it's put down the esophagus. Echocardiograms help to get more in-depth details of mitral valve, and it will show that MVP valve is going through degeneration, making it spongy, thick, and redundant, which we can see in the diagram. Echocardiograms on the left, MVP is in the systole phase, and MVP is in the diastole phase on the right.
Another form of diagnosing MVP is using a chest x-ray, which is an imaging test that projects what is occurring in your heart, lungs, blood vessels, etc. If someone has MVP, a chest x-ray will help diagnose by showing that the heart is enlarged through the x-ray. And the picture on the left shows mitral valve regurgitation occurring, and the arrows pointing on the area that it would be shown in. Another test is electrocardiograms, which goes by ECG or EKG, which is a test that measures the electrical activity going on in the heart using electrodes placed on the skin. If the ECG presents irregular heart rhythms, its diagnosis is mitral valve disease. And the picture on the right will show MVP occurring and the red arrows pointing to where the irregular rhythm occurs. If other tests mentioned previously don't help diagnose MVP, then a cardiac catheterization test will take place. It's not necessarily used to diagnose MVP, but it may be found when catheterization is used to diagnose for a different reason. In this test, a thin tube, known as a catheter, is threaded through a blood vessel in the arm or groin, all the way to an artery in the heart. Dye is injected through the catheter, which helps arteries in the heart chambers easier to see through an x-ray and display if the heart size is regular or if anything is out of the ordinary occurring in the artery. The picture on the left shows how the dye would pass through arteries, and if MVP was present, the plaque would get in the way of the dye being able to pass through. And the last test that would happen to diagnose MVP is an exercise or stress test. These tests involve patients to walk on a treadmill or ride a stationary bike while the heart is being measured with an ECG with electrodes and blood pressure cuff placed on the patient. These tests help show the heart responding to physical activity and help show if MVP symptoms occurred during the physical activity. If symptoms occur, the ECG shows that irregular heartbeats occur, and then the patient is likely to be diagnosed with MVP.
Overall, the prognosis for someone with mitral valve prolapse is very benign. With a complication rate of 2% per year, most individuals are asymptomatic. It is therefore known that most patients with the condition are unaware of it and do not require treatment. As a result, for the vast majority of those with mitral valve prolapse, their life will be unaffected by the condition. However, patients with MVP are often advised to see a cardiologist every 3 to 5 years to check on the progress of their condition and ensure no problems arise. Despite most not requiring treatment, severe cases require interventions. Surgery involves high risks. Thus, if possible, non-surgical treatments are first attempted. Because the biggest concern with MVP are the symptoms that the condition causes rather than the actual valve, the first steps in treatment are to reduce or eliminate symptoms. Medication can target the symptoms specifically through the use of beta blockers. Beta blockers reduce the stress of the valve, thus decreasing symptoms. However, the valve itself is not improved. Antibiotics and blood thinners have in the past been recommended in very specific scenarios. However, today, these are generally reserved for those who have had surgical treatment. Second treatment targets the mechanism directly through surgery, with two main types of surgery. The first type of surgery is a valve repair. The mitral valve repair is performed by removing the excess tissue responsible for the overlapping tissue of the valve. Valve repair has been shown to have a high survival rate, with fewer complications from the surgery itself. However, regurgitation can reoccur with this solution. The second treatment is a total valve replacement. A valve replacement involves the removal of the current mitral valve with a new valve put in its place. The new valve can either be a tissue or mechanical valve. Both have their advantages and disadvantages, and the decision between them will ultimately depend on the doctor and patient. In general, a mechanical valve has a longer lifespan. However, risk of blood clotting is higher, thus a blood thinner is prescribed to the patient for the remainder of their life. A tissue valve does not have the same level of risk of blood clotting. However, the lifespan of the valve is shorter. Therefore, if the patient is young, they may need to receive a new valve in their future. A valve replacement should only be considered when a valve repair is not possible, as it is a riskier surgery with a lower survival rate. Nevertheless, it is a necessary treatment for some patients in severe circumstances. Mitral valve prolapse is present in around 2 to 3% of the world's population, with about 3% in the United States. Although the condition can be diagnosed at any age, it is more commonly diagnosed after the age of 50, with severe outcomes increasing with age. Additionally, women are about twice as likely to have MVP than men.